This is Caesar with Nursing School Made Easy, and today's lecture is going to be on the gallbladder. It's going to be on cholelithiasis or cholelithiasis, depending on how you pronounce it, and cholecystitis. Now, cholelithiasis or cholelithiasis simply means stones in the gallbladder stones. And cholecystitis means inflammation of the gallbladder. Now, most of the times, cholecystitis, inflammation of the gallbladder, is caused by gallbladder stones. So let's jump into it right away. Again, these lectures are geared towards preparing you for the NCLEX exam for nursing students. So let's get into a little bit of anatomy, okay? First of all, let's draw a little picture here. Get a pen that works. So let's pretend, excuse me, it's chest, and then we have esophagus, stomach, okay, and on the right side, more importantly in the right upper quadrant, you're going to have the liver, right? And right behind the liver, you're going to have something, so it's going to be right behind here, it's going to be something called the gallbladder. So this should be behind here, okay? Now gallbladder is going to secrete bile into the cystic duct, to the bile duct. And liver is going to secrete some liver, just call it liver stuff for now, by way of the hepatic duct. These are going to combine to form the common bile duct. Now these are going to go down a little bit further, and remember, it's going to actually sit a little bit higher up here and have something called the pancreas. Pancreas is a little feathery looking organ, and the pancreas is going to secrete its pancreatic enzymes here. Now, just talked about, excuse me, cholelithiasis or cholelithiasis, gallbladder stones. Now, these gallbladder stones are usually due to large amounts of cholesterol. So, if somebody has a really high fatty diet, a lot of, again, junk food, that may raise their cholesterol levels, and may raise it to the point where they get stones. Gallbladder stones. Now the problem becomes, for example, if one of these small stones comes into here and perhaps gets stuck there in the cystic duct, well, now bile cannot get out. The gallbladder will get larger in size because that bile cannot be secreted, and that, for example, would cause cholecystitis, inflammation. Another thing is, these little gallbladder stones may irritate the wall, and again that would cause cholecystitis or inflammation of the gallbladder. Now we run into another problem if, for example, this stone travels further down, because now you have one, liver enzymes, liver secretions being occluded, you have bile secretions being occluded, and another thing that can become occluded is the pancreatic duct. So now pancreatic secretions become occluded, which can lead to pancreatitis. Okay, so that's just really brief anatomy and some physiology. So number one, remember, it's in the right upper quadrant, and this is mainly due to gallbladder stones due to increased cholesterol intake. So let's get right into it. What would some clinical manifestations be? Signs and symptoms that your patient may display. Number one, indigestion. Number two, pain. And we just talked about this pain. This pain will most likely be in the right upper quadrant. And also, a lot of patients complain of pain again in the right upper quadrant. That's very important that you know that for your nclex exam. And also, this pain will radiate to the right shoulder and right scapular region. So make sure you know these for the nclex. Number 3, along with that pain, you'll have some nausea and vomiting. Now the interesting thing here is that these two things will typically occur anywhere between 2 to 6 hours after a very fatty meal. You're eating a lot of cheese pizza, a double cheeseburger, anything really, really fatty. A couple hours later, that patient is going to complain of extreme pain. Along with that pain, you can have some nausea, vomiting. Again, that pain is going to radiate to the right shoulder, right scapular region. Now, if the pain is severe enough, you may even have some sweating or diaphoresis. Okay? So when you're asking or getting some history, ask that patient, are you having any of these symptoms here? Again, pay attention to the location of the pain. 5. Again, due to our location, you have some right upper quadrant tenderness. Maybe some rigidity when you press down, when you palpate that area. You palpate that area, are they guarding that area? And I just mentioned all of these here, but in some instances, some patients may actually be asymptomatic. And we'll get into that a little bit later. Now, again, I did say that a lot of these problems are caused due to these gallstones. And these stones irritating either the gallbladder or causing some type of occlusion. Now, in some instances, you not only have, you may have gallstones. In some other situations, you may have something called gallbladder sludge, kind of like a muddy consistency, and again, that's just cholesterol. And in other instances, you may have a non-functioning gallbladder. Now, in these scenarios, a non-functioning gallbladder, you may not have all of these symptoms. Okay, so that's the reason why these patients may be asymptomatic. Number 7, you may also have some jaundice. And again, this will be due to, for example, the hepatic duct and the bile duct being occluded due to a gallstone. Now, what are some complications that can arise from these gallstones and this inflammation of the gallbladder? Number 1, we just talked about this earlier, pancreatitis. And again, this is due to the occlusion of those ducts. Number 2, rupture of the gallbladder. These are not all, but these are the main ones that you need to know. Again, pancreatitis and rupture of the gallbladder. Now, this is very important because if the gallbladder does rupture, you can run into some of that bile being in the abdomen, in the peritoneal cavity, in those layers, so you can actually end up with bile peritonitis. You remember, bile is going to help digest fat. So if you get something that's digesting, something that causes digestion into your abdominal cavity, you're going to run into some problems, and that is why you would have some of that peritonitis. Now, what would some diagnostic studies be? Number 1, the choice, or the preferred thing to do is a gallbladder ultrasound. This would be the most inexpensive thing. Okay, and again, this is the preferred choice. Again, gallbladder ultrasound. These patients, you want to tell them not to eat before the study. I believe it is minimum of 8 hours because you want that gallbladder to be full. If they eat a large fatty meal, gallbladder is going to contract, it's going to get smaller in size, and the ultrasound will not be able to be performed. So make sure you tell that patient to not eat before the exam. Okay. Other choices or other things that you can do is, for example, CT, CAT scan. 3. Now, for example, if the patient turns out to have a non-functional gallbladder, then something like a nclex study will be ordered. And in that scenario, they're going to test the functioning, or the functionality, whether the gallbladder is functioning or not. So that will be a functional study. Again, nclex study. You will do some lab work also. Now again, to diagnose it will be most likely gallbladder ultrasound. Now, you may also be doing a WBC. The WBC will indicate if there's infection or not. We'll also look at the ALT, AST. Now again, these are liver enzymes. If these are elevated, it may indicate that the liver is being affected in some way, shape, or form. Maybe there is an occlusion, and this occlusion is causing these enzymes to become elevated. You will also look at your amylase, your lipase levels. If these are elevated, severe amounts, it may indicate that the pancreas is being involved. It may indicate pancreatitis. Again, that will be due to some type of occlusion. Now, what will be some therapy for your patient? And again, this will be determined whether there are symptoms or whether they are asymptomatic. And it also depends on, it also depends on how severe the symptoms are. If the patient can tolerate the pain and there's no occlusion, then maybe the only therapy you'll do is some type of pain control. If it turns out that there is a little bit of infection, well, then you may do some antibiotic treatment. Now, if, for example, there is severe inflammation, there is some type of occlusion, it's causing too much pain for your patient, then a cholecystectomy or removal of the gallbladder may be performed. And typically this will be done laparoscopically, so it'll be a lap chole. And ERCP may be performed. Now, an ERCP will most likely be performed if, for example, there is an occlusion of the common bile duct. So they'll go in and they'll remove the stone. So that is typically when the ERCP will be done. Now, ERCP, what that stands for, in case you want to know, is endoscopic retrograde cholangiopancreatography. Okay, so that's ERCP. Now, if, for example, a lap chole is performed or a cholecystectomy is performed, sometimes that patient may have a T-tube put in place. Now, the T-tube is going to help drain the bile. Okay. Now, what are some interventions that you will do for your patient? Number one, you're going to help control pain. So do some pain control. Do some NSAID administration, maybe some Toradol, for example. Number two, you're going to control that nausea, vomiting. Number three, if, for example, they do have some type of surgery, they do have a lap chole, you're going to assess, you're going to monitor those surgical sites. You want to make sure that they look good. They're not red, they're not edematous, there's no discharge, no purulent discharge, there's no active bleeding occurring. Okay, so you're going to look at those surgical sites, you're going to assess that patient, and you're going to make sure that that patient isn't bleeding profusely, that those wounds, that those incisions look nice and clean, dry, and that they are intact. Now again, we're going to move into some interventions for patients that do have surgery. So number one will be check the surgical sites. Number two, you're going to ambulate your patient. Now, what occurs in a lap chole, let me draw an image here. You're going to have abdomen here, you're going to have belly button, chest region. Okay, so again, we're going to talk about the right upper quadrant. So in a lap chole, for example, there may be a scope site here. So a camera may be put in here, and then another incision may be here and here. So a scope will come in here, another scope will come in here. They will come in and clip the gallbladder out. Okay? But what will end up happening is they'll expand the abdomen. They'll pump in some gas to kind of, if you can think about it, kind of like a balloon. They'll expand the abdomen. Okay? Once the surgery is done, these scopes are removed, and they will put some bandages there and here. So again, you're going to check these for bleeding, for discharge. And again, you're going to ambulate your patient. Well, why? Well, like I said, they're going to be pumped full of gas. Sometimes that gas is not completely removed. They try to do the best to get rid of all of that gas. Sometimes you can't get it all. So what will end up happening is that gas will travel up into the shoulder region. Okay? And they will begin to complain of shoulder pain, maybe a little bit of chest pain. So the best way to get rid of that gas is to ambulate your patient. So you want to perform that immediately. So inform your patient also, hey, listen guys, if you begin to have some shoulder pain, the best thing you can do is ambulate. The other thing you're going to do is you're going to give them good old IS, or incentive spirometer. And you're going to tell them to use that. So please make sure you know how to use your IS, and you tell them to use that every hour, okay? Depending on your facility, you might use it more often, but at minimum, once every hour. Again, you're going to try to prevent pneumonia. You're going to try to prevent some type of lung complication, because remember, they're going to have right upper quadrant pain, and if they came right out of surgery, they're not going to want to take deep breaths in because it hurts. So make sure you let them know that they must use their IS to prevent pneumonia. And again, this goes back to taking care of that pain. Please medicate your patient appropriately. Don't do it excessively, but make sure that they're comfortable. If they're comfortable, their pain is under control, they will more likely than not ambulate and use their IS. Okay, so please keep them comfortable. Number 6. The book talks about this. It talks about placing your patient in a Sims position. So remember that for your nclex, because I have seen that on a lot of practice questions. So you're going to place them in a Sims position. So again, you're going to take care of their pain. You're going to make sure you check out those surgical sites. You're going to ambulate them. You're going to make sure that they use their IS. When they get ready to go home, you want to tell them to avoid spicy foods. And also avoid fatty foods. Okay? Why? Well, your brain still thinks you have a gallbladder. It's going to send a signal, hey, gallbladder contract. Okay, so you might get some of that phantom pain, or you will have some actual pain because you just had an incision here. So anytime you eat a fatty meal, that area is going to contract. So if you want to avoid some pain, you want to tell your patient to avoid fatty foods. Okay, that may be between 2 to 6 weeks depending on what your physician tells them. Number 8, you're also going to tell your patient to avoid heavy lifting. You don't want that patient to go and pick up something that's really, really heavy and end up opening up these incisions, especially the one down here. You don't want to end up later on with like an inguinal hernia because of some weakness caused by excessive lifting. Okay?